I can tell you we will not be calling this swine flu today. We will be calling this H1N1 virus because it's been very clear that the World Health Organization today told us that as we continue to talk about this as the swine flu, there have been many, many actions throughout the nation and the world in terms of finding pigs throughout this entire world and killing them. And in many cases, the World Health Organization told us this morning that there is not a connection. So we want to make sure, members, as we begin this, as we also educate the public, I will say thanks to Cal Channel for putting this on statewide live today. I hope they will run it many times. And I also would like to inform the public that the Senate will have this on webcast in a few days, and it will be simulcast in Spanish. So we have an opportunity for our populations in California, many of which have relations in Mexico, to also become educated as we begin this particular proceeding. I would like to thank the administration for all of its hard work. We don't know this is somewhat of a pressing emergency. We're going to begin the hearing this morning with Dr. Bonnie Sorensen and Dr. Steve Thurratt, but I understand they are briefing the governor as we speak. And so we expect them, members, somewhere within the hour. And I would ask the governor's office if they are within listening distance. We do expect them here. We would like to ask them some questions on emergency response and particularly what our health plan is. But because of members' time, we're going to begin with our panel 2. So if you are on panel 2, I'd like you to come up to the dais. As you are, I'd like to say a few statements. I'd like to have members say a few statements, and then we'll proceed on. Let me also say, if Linda Davis Alderette can also come up, although she was in panel 1, we'd like to start with our schools at the very beginning of this. So please come on up, and we'll make room for everybody here. As you're coming up, I'd like to say, as I've mentioned earlier, this is probably the time for all of Californians to come together. We need to know whether or not we have a very logical, calm, and straightforward plan. And there are many, many questions. I know members have many questions, as has been evidenced by the folks sitting up here today. I can tell you that the overall goal of this is to make sure that we are not in a, if I could use a quote, we don't want to alarm people, but we would like to be alert. And I think being alert is extremely important for Californians as we begin to see this unraveling, particularly with our schools and in many other institutions from the county level all the way up. Today is really, I'd like to hear a couple of things, and I know members want to hear some things, but let me tell you what I would like to hear. First, we'd like to get a basic understanding of flu epidemics. We'd also like to understand the control and command structure that we have here in the state in order to show that we are prepared. And I do believe we are prepared after talking numerous times to the governor's office, but we want to make sure that we're ultimately prepared. We also want to have an honest discussion about resources. We want to have a real honest, blunt discussion about whether or not we're providing the resources to the locals, who in many cases, even as soon as yesterday, talking to some of our county health officials, are working overtime. And at a time when many of our counties are laying off folks, this is a real resource issue that we should begin to have discussion on in terms of personnel. We'd also like to make sure that the messages being sent out on this particular epidemic are being sent out in the appropriate manner. And that means in all languages and in all communities. And so we're going to have some discussion with the governor's office, hopefully on the diverse population that California has, and ultimately making sure we're using the right language. With that, I'd like to thank Senator Alquist, particularly my colleague, my long-term colleague from the Assembly days, now here in the Senate. I'd like to have her say a few words. But I would just like to end by saying, for those listening, we want to make sure, as I mentioned, the line between alert and alarm, that I believe the U.S. flu season, the normal U.S. flu season, about 5 to 20% of our population get ill in our normal flu season. And that means in our normal flu season, at least according to statistics, 36,000 Americans die. I don't think we've seen that yet in this particular flu. And so we want to make sure that we are putting it in context, but more importantly, making sure we're prepared if this thing gets much worse. So I will turn this over to Senator Alquist for opening comments, and then we're going to go to Assemblymember Jones, who's the chair of this Assembly Health Committee, and other member comments, and then we'll begin.
Thank you, Senator Flores. As chair of Senate Health, I would like to thank all of you who came today, as well as all of you who will be watching this on cable. we all understand that this is now classified as an imminent pandemic by the World Health Organization. I understand from the health officer in my own district in Santa Clara County, Dr. Marty Fensterscheib, that the Department of Public Health has been very responsive in working well with the state's local health officers and the CDC. I would also like to thank the federal government, state, and local officials who I believe are doing a really good job. Marty, my health director in Santa Clara County, has indicated to me that individual cases of H1N1 virus that we are currently seeing are sprouting up across the state and could transform into something really horrible. He rated this as a 7 out of a 10 in terms of how serious a health threat, public health threat it is. And we are beginning to see that there have been and will be more American deaths. It appears in my county, in Santa Clara County, we have 4 likely cases, and another 19 cases are being tested as we speak. One case in my district of a 16-year-old girl who traveled to Southern California has led to the closure of Branham High School in San Jose this week. Dr. Fensterscheib indicates that he is 99% certain that this is the H1N1 virus, and he is just awaiting confirmation from CDC. I also understand that the strategy at this given point, where, and I've asked some pointed questions of health officials along the way, where we already are in the life cycle of the illness that we can no longer contain, and that our focus now has to be on how do we slow its spreading. It's my sense from speaking to Dr. Fensterscheib that you are doing due diligence at the federal, state, and local levels, and we're doing what we can to mitigate the impact. I'm eager to hear from you and to have some specific questions answered as to what has been done and what can be done. I view this as we are learning together something every day, and that we have to take it day by day, and that it is important to maintain a calm approach to analyzing the problem in the midst of a flu that has killed and will continue to kill Americans. As always, it heeds us to both work and look at the current situation as well as planning for the flu season next fall. So thank you.
How does this flu kill individuals? What's so special about it that takes us to that next level?
The descriptions that we've heard in the 1918 pandemic are just graphically frightening. When the influenza gets into the mucous membranes, into the lung and the nose and the mouth, the body responds by exuding fluids to try to fight off this infection. And folks in the pandemic in 1918 literally drowned and suffocated in their own mucus secretions into the lungs. So people were described as just turning blue and coughing up frothy, bloody stuff was just exuding out of their lungs. So a very severe virus can be devastating. But at this point, fortunately, at least in this country, the virus is mild. Folks are recovering. We've had 6 hospitalizations, but folks are getting out of the hospital and recovering. Obviously, if elderly or more medically complicated folks catch the flu, we expect to see more illness and potentially death in the state.
And so I think it's fair to say it's treatable early on.
Yes.
Okay, because I think there's a lot of misperceptions out there that once you get it, you get it. How is it spread among individuals?
How is it spread?
Yeah.
It's spread by what we call droplets. It's not just in the air. If I had the flu, it wouldn't be as far as you are from me. But it's spread by the droplets. So when we see the picture, or all of us have had the experience of seeing somebody sneeze, and you see those vapor, the water particles, droplet particles in the air, that's one way it can spread. The virus is in those droplets. If you're within 4 to 6 feet from someone who sneezes and doesn't, or coughs and doesn't cover their mouth, you can inhale that and get the flu. The second and probably more common way that it is spread is that the virus being incubating in the nose and the mouth and the lungs, if people who are ill proceed to scratch their eye or scratch their nose or pick their teeth or lick their fingers, they then have transferred that virus onto their hands. If they then go and handle this microphone or a telephone or a remote control or a doorknob or a handrail, they have then deposited that virus on that object. The virus can live up to 2 hours on that object, so the next person that comes along handles that object, has the virus now in their hands. If they wash their hands meticulously before touching their eyes, nose, or eating, they can prevent getting the virus even though they've been exposed. But if they don't, if they're not heeding that very simple advice, then they essentially can self-inoculate themselves with the virus.
So there's inanimate objects. We've seen some videos, at least I have, the schools, if you will, disinfecting the desk in some cases. And is this the right approach?
Well,
from your perspective?
Schools are special occasions. Why are we so interested in the children who are ill in the schools? Why are we recommending closing a school when there's a case compared to, well, what if we have a case in our workplace or a case in Walmart? The reason is that children are much better spreaders of virus. Plus, the younger the children are, the less really cognizant they are about hand hygiene. They touch each other a lot, they have hand-to-mouth, and they're all handling stuff in the school. So yes, disinfecting the school would help, but it would have to be done on such a regular basis since the virus really doesn't, maybe maximally if the virus was on a surface that was dark and moist, it could live up to 24 hours. After 24 hours, the virus is all dead. So that extraordinary disinfection of the school is more an exercise of show.
Gotcha. And in terms of the estimation of how long this particular season will last, do we have any thought process on this particular strain and flu?
The presumption is that this will last about as long as our normal seasonal flu, so 2 to 3 months. Okay. A concern that we have is that in the past, when we've had pandemics, the pandemic has had phases. So the first phase has been relatively mild. Then the virus goes away, but it comes back. And when it comes back, it's had time to mutate and become more virulent. So there's a great concern across the country amongst all of our scientists, experts, that despite the fact this is apparently mild, and maybe we're overreacting and becoming overly concerned about exposure to it, that in the fall it could be back with a vengeance.
As we have more publicity about this issue, as people become, if you will, sick with a regular flu or a flu in general, in many cases the emergency room probably be one of the first places that a lot of folks might begin. How are you handling that? Is there a protocol for that? Is there something that the state's doing in terms of organizing with you? And the Hospital Association could jump in here as well. But what is the state doing in our strategic plan at this point in time with management of the emergency rooms, the information that you're providing? Just give us an overall, and I'm sure members will have some questions on this as well.
Most of the information I receive is from the CDC on how to handle the influx of patients that we've been receiving for the last 3 or 4 days. As far as plans go, I mean, that's a great question for me. We would love surge capacity plans in every hospital, which we don't have, and that's something that we've been pushing in the emergency department for a while. So, we feel that we're underprepared for any type of disaster management in the emergency room, and we're pretty much on capacity at all times. So every day we are overcrowded or at capacity. And so when we get an influx like this, we're pretty much overrun, or we are overrun. So if the I mean, our fears are, right now we have a lot of healthy patients coming to the ER or with minimal symptoms. If we had, significantly sick people on ventilators, we don't have anywhere to put them. I mean, our ICU was closed. We didn't have any room in our ICU on Saturday, and that wasn't even when we started seeing the influx.
I think there are at least two different questions. One question is, how do you deal with a large number of people, all who seek help in the emergency room? But a different question is, we know that someone who has this virus ought not to be sitting with 25 other people in a waiting room for 6 hours. So what do you do before that person gets in to see the emergency room doctor so that he or she is not giving the virus to somebody else? What are your first thoughts on that?
Yeah, to answer your second question first, because I think I kind of addressed the first one earlier. Every hospital or emergency department should have a plan in place for that. I don't think all do. And there are hot zones and cold zones that you associate with any infectious disease or radiation exposure or hazardous material. And if your hospital is set up to deal with that, and I don't think most are, but some are, you have tents outside and you determine where the hot zone is and where the cold zone is and where the decontamination occurs and triage occurs. There's been tents set up already in California outside hospitals because we can't handle the triage at this point. And those tents usually act as a hot and cold zone for decontamination.
That's a real issue. And just to mention to my colleagues from both houses, I just had a bill, SB 769, my bill that got through our health committee, and it's currently worded to be a vehicle for accessing federal stimulus dollars for wellness and prevention, and I'm wondering if we can sort of redefine wellness and prevention in terms of this outbreak. Thank you.
Curious about reporting. Is there a methodology for you and the ER personnel to report cases that's pretty clear and streamlined?
Yeah, it probably took a day or two to become clear, and I don't think from the top down they had a plan in place right away. So there is a reporting now. All flu has been, since 2007, notifiable, so that doesn't mean they've been having surveillance on it, but we were supposed to notify in flus, and then they check the different strains that are out there. But there hasn't been surveillance run, so this is really the first time that they're, surveying a certain virus. But yes, we do, if a certain set of criteria are met, then there is a process in which we swab the patient and send it to the certain CDC-approved site for further evaluation.
And to another question, how do you feel about, are there, in terms of numbers, enough personnel for all this? And for the benefit of the public, could you explain triage?
I apologize.
Oh, no.
To answer the first question, no. I think every day we don't have enough people in the ER. We're always overcrowded. So when we get hit with something like this, we're overrun, and now people are just waiting longer than they were waiting before, which was long. So no, we don't have enough personnel.
If you're documented or not, is that an issue?
Not from my standpoint, no. Anybody that comes into the ER, I don't ask if they're documented or have insurance, or I just see them.
Community clinics and health centers are significant providers of care in the state of California to the uninsured population, and the immigrant population was also mentioned as well. And keep in mind that statewide, community clinics are the medical home to 55% of our, 55% of our patients are Latino. So we are significant providers to the populations, and we're sitting on the front lines. And what I wanted to make you aware, while I'm not an expert on some of the issues of the disease or the protocols even within our health centers, I do want you to know that this virus has impacted community health centers throughout the state in some significant ways. First of all, we have seen an influx of patients with potential influenza cases, as well as increase in treating the worried well, those that self-diagnose, and they have flooded our facilities seeking care. And in fact, some of our health centers have reported a 25 to 30% increase in patient flow this week alone. So the demand on our primary care clinics throughout the state is rather significant. Second, with regard to public health communication, I appreciate this being raised here, many clinics, and we also have 14 regional clinic associations throughout the state that represent clinics in local counties and serve as a local hub for our clinics, are reported to CPCA that they are having significant difficulty in staying in close communication with their local public health departments. This is very disappointing to us during this critical time of need, that the community health centers are being forgotten, that we are at the front lines here. And this really limits their ability to detect and treat suspected cases. In fact, the California Health Alert Network was mentioned earlier, and unfortunately only a small portion of clinics are part of that at this time. So we are concerned that without more close communication between clinics, public health departments, and the broader healthcare delivery system, that this viral outbreak could continue longer than necessary. So we really want to urge a close look at that issue. Thirdly, on the resources front, and this is probably the most important point I can make here today, and I think it's something that's been touched upon here. Only a portion of our 800 California clinics in the state have personal protective equipment on hand for their staffs. And only few have caches large enough available to tap into, particularly in the case of a sustained infectious outbreak. Now, in the past week, a good majority of our clinics that have communicated with us, and including the regional clinic associations who communicate on behalf of their local clinics, are reporting that their counties have informed them that the county would not be supplying them with personal protective equipment or a medication at this time. Being told that those resources lie at the local hospital level. And this is very distressing. And if there is a plea that I want to make to you today as legislators, and certainly when the public health department comes forward, because our attempts to communicate with them have not been responded to thus far. There is a tremendous need to get these kind of equipment to our health centers. We are talking about the very masks that were discussed here earlier that our staff need, as well as the patients, that there are clinics that do not have adequate supplies and access and are being told that those will not be provided by the county. Protective gloves, clinics need more of that as well. That is not being provided. So we are very concerned that although these medical facilities are at the front lines and can play a very important role in screening. I mean, many of our clinics have the labs on site. I mean, we are equipped in many ways to handle this. We can serve a variety of public health emergency response roles based on our capacity and our capability, and that ranges from surveillance to triage to translation, but only when we have the right training, the right equipment, the right supplies, and the right communication at the local level. So as this viral outbreak unfolds, I think it's really critical that at the state level and at the local level with our counties and our public health departments, that we recognize that community health centers are at the front line serving literally millions of patients, and particularly with concern of the low-income, uninsured population, that we can play an important role in effectively fighting this virus, but we're going to need continued and increased support and communication.
I mean, I think the purpose of the hearing is that because we have a disaster assistance plan that you're a part of, that you've already had these communications with the folks who are administrating it. And I've heard this from our hospital association, and they're saying communication isn't where it is. There seems to be a disconnect at our emergency rooms. Now you're covering the 40%, particularly the poor, the undocumented, and folks without insurance. And I'm going to use your words. You said you have many attempts at communication. You used the word forgotten. And so I'm wondering, if you're part of our strategic plan, how could you be forgotten? Because you're supposed to be providing a service in an emergency that should flow seamlessly.
I mean, part of the reason I think is because we think of emergency, so hospitals come to the forefront, and I think they have a very important role to play.
Right.
And the reason why I think we may tend to be forgotten is that frontline role in primary and preventive care.
Okay.
That when it comes to influenza, I mean, a lot of people are going to go to their primary care provider, and even for the uninsured, they do have a medical home in our community clinic system, and I think that's.
Let me ask another resource question. You mentioned gloves, and Bruce wants to jump in, but let's talk about Tamiflu for a moment. The feds are saying they're sending enormous amounts to California to cover at least a quarter of Californians. I think that's somewhere in the millions. Now, is that getting to you? Are you prepared? You say you saw a 40% increase,
I'm so
25 to
glad you mentioned
30%
that.
increase. you know.
That is one of the very issues that has been mentioned by our health centers. When they have contacted the counties to ask for the supply of this medication, they are being told that that is going to be provided to the hospitals. So we are here today because we want to make sure that when these supplies come to California, that community clinics are not forgotten and that we are part of the distribution system, because we are in the front lines and we have a role in primary care and preventive care.
I get it, but what, and so you won't have enough Tamiflu is what you're telling us.
That is our concern, absolutely.
Right, and you're saying that our strategic plan directs it through the hospitals, and somehow in the strategic plan, you're not included.
No, what I'm saying is that we, the counties have a large role in the distribution process.
Yeah.
And they
Got
need
it.
to be more aware and concerned and bringing in the community clinics. We need to be a stronger part of the partnership. While we're in that plan, I think that what needs to happen in the reality of how it's being operationalized, there needs to be more attention paid to the primary care system,
Right.
specifically community health center.
You're saying that about a good percentage of your clientele are traveling through the immigration route, in many cases, from Mexico to work here. I mean, it's just a reality. So, but yet, wouldn't you be the first place we would put loads of Tamiflu?
Senator, that's why I'm here today, because we are extremely concerned that
Yeah.
for some reason we are not rising to the top on the priority list, and we believe that needs to change urgently.
Okay.
When the first guidance went out from CDC, hospitals began reviewing their plans. They were looking at what they needed to do in order to ramp up for this potential event. One of that was CDC had told that recommendation was to get and acquire Tamiflu and their masks and other supplies. And we got numerous calls about, we don't have Tamiflu, we can't get Tamiflu, we can't get it from local pharmacies or manufacturers. Now, if you were the pharmaceutical company, they have been inundated with calls as well. This is not a new issue for the state. This is a gap in the plan. There's no operational, but before the operational piece, there's no way to prioritize, to allocate and distribute the multiple healthcare providers within the system. This has been something that's brought to their attention for numerous times, and unless there's been a change, a couple days ago in a conversation with the state, I had suggested, I asked if any of the local LIMSs or public health assessed the healthcare providers to see what actually is available. What do hospitals have? Because I don't know how you could make a decision without assessing some of that and identifying it. And I was told that was not in the plan. That could have changed since then. But I think these are critical points to consider when we're looking at very limited resources. If they're limited, they need to be given guidance on how they're going to be used.
So who does make the decision with regard to the distribution of the California stockpile of antiviral treatment, which I believe is about 3.7 million courses based on what
Well, that would
I have?
come down from the Department of Public Health to the local public health, is my understanding. But
And so DPH makes the decision as to which counties get how much. And it's my understanding that about 50,000 courses have been requested by San Diego from that stockpile. I don't know if we have any information about other counties making requests. So, but it's DPH that makes the determination. And what you've said is very disturbing, and that is that there really hasn't been any effort, at least to your knowledge,
To my knowledge.
to survey the availability of these courses of treatment that, in terms of existing stocks at frontline providers, whether they're clinics or hospitals, and what their needs might be, in order to try. And nor has there been anything in the plan with regard to how you determine prioritization in terms of allocating the scarce resources we have in the event that we need to do that. That's the
That is
concern.
correct.
Well, that is disturbing, and I appreciate you bringing that up. It's very troubling to me. I'm sure it's troubling to the other members of the committee, and my hope is we'll have a chance to ask that very question of the administration and their representatives in the next panel.
The panels were switched earlier.
Sorry about that.
And let me tell you what the members heard, in fairness. We heard that you talked about preparedness, and we heard there were no surge capacity at emergency rooms, no overall budget in terms of the personnel necessary at the county level, especially for public health officers. We heard inconsistent communication with our hospitals and no plan for them in terms of being part and parcel of the response. That we've heard from our clinics as well as our emergency rooms that there's no consistent or organized communication with the state at this point in time. We heard that there's a lack of communication with community clinics, and particularly in the diverse communities in terms of their language. And they were not able to access gloves from the county level or Tamiflu. And of course, I think we heard throughout this hearing in the earlier panel that there was very little prioritizing or allocation of resources. That's the context in which we're going to be asking you some questions, because had we not had that panel, we probably would have listened and said, sounds like everything is wonderful. Now that the panel went before you, I think we have probably some questions. I'm going to ask Senator Elquist to begin.
Sure.
Nice to see you.
Thank you.
You probably will want to get a video of everything we said earlier. So how do you prioritize, allocate resources for both providers and patients?
Related to the allocation of the antivirals, which is really a
That's
primary,
part of the question, yes.
primary concern, the calculation of how many antivirals the state should invest in was based on the federal recommendation that we should stockpile in each state enough antivirals to really treat 25% of the population that becomes ill. 25% of the population, assuming that 25% of the population would be ill enough to require treatment. So that's how we came up with 9 million-ish courses of antivirals. As you've already mentioned, the state purchased 3.7 million courses of the antivirals, where the federal government has stockpiled 5.3 million courses of antivirals on behalf of California. Our allocation methodology was really by population. We have taken the total amount of courses and basically allocated it according to population in each of the respective counties. In fact, our warehouse is organized in pallets of all this supplies and antivirals, and each has a name of a county on it. So earlier this week, when we began deploying our state stockpile of antivirals, we just asked the locals who was in a position of not only wanting it, and needing it, but also being able to receive it and store it. Sure.
Need a few specific answers. So number one, how many more to combat the virus do we need? We've stockpiled how many, and that means how much more do we need?
We have stockpiled enough to treat the 25% of the population in California that's expected to become ill enough to require treatment in California.
So you think we have, you're on record as saying you think we have enough. That's a first.
For the first phase of this, as you're probably aware.
And first phase would be for the next 3 months, but
yes.
not even counting what could be a worse season
exactly.
by next winter. So for next winter, we have nothing.
Depending on how much we use this phase, you're exactly right.
So on your list, you have, we might be covered for what happens now in the next 3-4 months, but one of the things we need to be doing is seeing that we have enough to protect us for next winter, which could be a whole lot worse than this bout. So that's the first question.
Sure.
Second question is, how do you prioritize and allocate? I mean, we heard over and over that, we don't have the supplies either for the healthcare providers or even for the patients. I even raised the smaller thing of, you're waiting in a waiting room. You're there for 5 hours. Are you being given a mask, or are you put in a tent, or, that level of detail? So, and we had the community health clinics say that, they don't even know if they're quite in the loop in terms of getting the resources from the Tamiflu to the mask. I mean, so can you answer that? And then also tell me where it is in writing.
Yes, the pan-flu planning, which has been going on for years, in which our legislators have heavily invested in over the past several years, requires that each local county have a pan-flu plan that feeds up into the state plan. Each of our counties is expected to work with their respective healthcare providers, not only hospitals, but also primary care clinics. And when we allocate resources down, we don't allocate specifically to a hospital or community clinic. We allocate to the county, and then they are responsible for distributing it locally. I might add also that the hospitals, as well as the community care clinics, have been included in the federal preparedness dollars and have been part of our funding distribution through the years to create their own plans.
Okay, number one, do you have a plan on date today from every single county saying how they would deal with this crisis? And as of today, you've approved it.
We have a plan from every individual county. I think part of the challenge here of pan flu planning, the reality has been it's not been very real, and therefore it's been difficult to get partners really to sit at the table and basically consider these worst case scenarios, and therefore the plans are not to the detail that you and I would probably.
Right. And I know you're in a tough spot right there, and I know there's a lot going on, but I'm also going to say, you know, this week, I mean, have you sat down with a representative from each county this week and looked at each plan and to figure out, given this swine flu crisis, that the plan is certainly up to date and contains all the elements for resources for interoperability, of moving resources from one county to another, that each plan would be one where you'd be willing for you and all of us up here to be living in that county?
The answer to your question is I don't believe our plans are that detailed. And yet we are speaking to our local health departments on a daily basis. We had a call today of 1,500 lines to speak to all the hospitals, nursing homes, and primary care clinics who wanted more information. CDC every day is putting up guidance, and we are discussing the guidance on a daily basis. Today or last night, the health care provider guidance was released. So that was why we had the call today to provide, push that information out. We also work closely with our medical association. They've offered to push information out to each of our providers as well. So
given the time crunch that we are really in, because we're talking about, you know, not to be dramatic, because it's not being dramatic when we're talking about life and death, but do you have a process for next week to actually really scrutinize every single county's plan and to give it your stamp of approval?
Do we have a plan to do that?
Are you going to do it?
That's not on our plan for next week.
Okay, I would suggest you might want to have it for next week, because for some people time is really running out. And that leads to my last question, then I will stop. I know other colleagues have questions. Going back to the prioritizing and allocating resources for providers and for patients, lady from the community clinics said that, you know, she felt that they just may not be included at the level that they weren't a high priority. Not that they weren't included, but that they were not a high priority. And given the population that they deal with, it is really important that they have resources, because otherwise everyone's going to be affected. So what is your communication with the clinics?
Well, I totally agree that our community health clinics all across California are the #1 priority. Not only folks who aren't able to have insurance and have a place to go, but many of our community members depend on our community clinics across the state. So that is a very high priority. In terms of really scrutinizing 58 plus 3 individual plans, the way we've been managing it, for example, related to the antivirals. Many of our counties did not have plans that were as granular as need be in terms of, well, how do we prioritize, not only in terms of where the antivirals distributed in terms of community-based organization, hospital, primary clinic, but also when it's distributed, which population, the antivirals are specific now being recommended for sick patients as well as close contacts who are taking care of those folks. The antivirals were not purchased just for folks who want to take antivirals to hope that it'll avoid or that it'll prevent, the influenza.
So how many masks have you delivered to every provider in the state of California?
We have not deployed our N95 stockpile because we're really just beginning to hear that folks are having difficulty with the pipeline, the supply pipeline.
Now, the other testimony we had today went to the capacity of the public health officers in each county to deal with this challenge. And it was pointed out that in many counties, if not in all counties, because of the fiscal problems that counties are facing, they're preparing to cut many of the very same frontline public health workers that we need to both assess and respond to outbreaks of this flu throughout the state. And so the number we were given is that, and it was an initial estimate, and the public health officer's representative promised to provide us in the state administration with a more detailed assessment, but the number we were given was something on the order of $100 million to get us through this. Does your department or does the administration have the budget authority to provide that level of funding to the public health officers so they can keep people in place and not lay many of them off on July 1st, as the case maybe in many counties?
The reality in California, unlike some other states, is that the counties are independent jurisdictions from our state department. They're all county employees, and the dollars that we as a state provide to the locals have mostly been about purchasing protective equipment and doing planning, some people. But we do not have the cash nor the authority to be able to assure that the appropriate number of public health employees, particularly our laboratory workers, can be retained at the local level.
I think what we heard today is that we have a problem. It's one that is endangering Californians. It's one that may grow. We don't know specifically whether, in fact, this will emerge into a full-blown pandemic or epidemic, but we are very, very wise to be planning and taking steps to be prepared in the event that it does. I think we also discovered, though, that there are significant and important gaps in our preparedness. We heard today specifically that the public health officers have significant unmet resource needs, which are made all the more problematic by the budget circumstances in which the counties find themselves. And in fact, we heard as well that some number of public health officers are going to be laying people off. We heard, too, that there is a problem with communication, that many providers are not participating in the California Health Network or Health Alert Network, and that a number of provider associations are willing to encourage their members to participate, but it really raises the question for me as to whether, in fact, we should require participation, particularly at a moment like this when communication is key. Every exercise that I've been a party to when I was senior advisor to the United States Attorney General in the 90s, where we gamed out and modeled and did exercises around biohazards and epidemics of this type, indicated that one of the biggest problems was communication and the lack thereof. And certainly not having all of our providers in communication with the state's public health authorities is a problem that we need to remedy. We heard as well that, and I think there was agreement across the board in both panels, that there are significant gaps in the county's plans with regard to prioritizing the antiviral treatments, how one allocates those, who gets those. We heard from the chief deputy of DPH that they're taking steps to address that, but it's a problem, and I would encourage them, as they committed to this body, to take very aggressive steps in the days and next week to make sure that within those county plans there is more specificity and more guidance in terms of how best to prioritize the allocation of the antiviral treatments that we have, because we heard from the providers that's a big question on their minds, and it is an issue. So, Senator, I really thank you for joining with me and Senator Alquist in convening this. I think it's been an extraordinarily helpful and productive hearing. We've gotten tremendously important information out to the public at large, as well as informing ourselves about what we need to do in the legislature, working with the administration to make sure that we are as prepared as possible to address this problem. Thank you.
Thank you, Assemblymember Jones. Let me just close and simply say I think it's pretty clear we have a lot of work to do. And so I would ask and hopefully ask our chairs of our health committees to, when we have this transcript completed, to let's go through this, and our vice chairs as well, and we actually need to have a further discussion with the administration on closing some of these gaps and trying to make sure that as we're prepared that these gaps hopefully don't occur right before us, which I think is really what happened quite a bit today. So we have a lot of work to do. I want to thank the members for joining us, and we will, of course, as always, we'll have a letter to the administration in terms of what we've heard and what we think they need to do to close the gaps, and we will distribute that, hopefully jointly. So we'll get it all to the members' offices to make sure we're right on par in terms of what we heard. And with that, we'll adjourn the hearing of the Select Committee on Disaster Preparedness and the Assembly Health Committee, as well as the Senate Health Committee. Thank you all for joining us.